Alright, ladies and gentlemen, this is Mr. Williams. I want to talk to you about Chapter 23, start a lecture on abdominal, hematologic, gynecologic, genitourinary, and renal emergencies. You look at your chapter objectives and your key terms, figure out what we're trying to set out and accomplish here. A little overview of our lesson topics: acute abdomen, hematologic emergencies, gynecologic emergencies, and genitourinary renal emergencies. Abdominal pelvic pain has many causes, can be caused by a lot of underlying conditions. There's several pathology reasons that you can have things manifest in the abdomen and have outward signs that cause an emergency. Our care includes managing our life threats, of course, and making the patient comfortable in transport. Hematologic disorders are disorders of the blood and its components. And gynecologic emergencies can present with abdominal pelvic pain and vaginal bleeding, and some gynecological emergencies can actually be life-threatening. Renal disease is common, and EMTs commonly encounter patients undergoing renal dialysis. Okay, without further ado, let's have an introduction of our abdominal structures and functions. The abdominal cavity extends from the diaphragm to the pelvis, and the parietal peritoneum lines the abdominal cavity, and the visceral peritoneum is in contact with the organs. The kidneys, ureters, pancreas, and abdominal aorta are all considered to be retroperitoneal, which means they're towards the back side of the peritoneal cavity. The abdomen can actually be divided into 4 quadrants, or 9 regions, as reference points for assessment. The abdomen contains several different types of organs. You have hollow organs, solid organs, and vascular structures, each performing unique and individual processes. And just to reiterate here, the abdominal quadrants and regions, the organs can be located in the intraperitoneal or retroperitoneal space, and to drive it home, the abdomen is divided into 4 quadrants for reference. As you can see here to the left side of the diagram here, we have, if you're looking at a patient, it's in relation to anatomic position. So you have a left upper quadrant, a left lower quadrant, a right lower quadrant, and a right upper quadrant. Your left upper quadrant contains most of the stomach, the spleen, the pancreas, and part of the large intestine. The left kidney is behind the abdominal lining. The right upper quadrant contains most of the liver, the gallbladder, and part of the large intestine. The right kidney is behind the abdominal lining. The right lower quadrant contains the appendix. It's kind of a worm-shaped structure extending from the beginning of the large intestine, and really and truly nobody even knows what the appendix is actually good for. We can't determine what the function of it is. Part of the large intestine as well, and the female reproductive organs. And then the left lower quadrant contains part of the large intestine and the female reproductive organs. If you also pay attention to the right side of the diagram, we have the diagram dividing the abdomen into the 9 regions. Going from the patient's left to right, we have the upper row, which is the left hypochondriac region. The middle portion, upper, would be epigastric region. Then the right hypochondriac region. Going back on the middle row from patient's left to right, you have the left lumbar region, the umbilical region, and the right lumbar region. And on the bottom row, from the patient's left to right, you have the left iliac region, the hypogastric region, and the right iliac region. So what exactly can we find in the abdomen? Well, the abdominal cavity contains 3 different types of structures. We have hollow organs, solid organs, and vascular structures. Hollow organs contain some type of substance that might leak into the abdominal cavity if the organ is perforated or injured. It's kind of like, think of Tupperware. A hollow organ has structures to the outside, but it can contain things inside of it. Solid organs are vascular. That means that they have a lot of blood vessels and carry a large amount of blood through them. Some are covered by a thick fibrous capsule. When a solid organ is ruptured or injured, it tends to bleed. potentially leading to severe shock. And vascular structures are the large blood vessels found in the abdominal cavity. Portions of the descending aorta and the inferior vena cava are in the abdominal cavity. Rupture and injury to either vessel can result in major bleeding, rapid blood loss, and a probable quick death. So if you have a rupture of a large blood vessel inside the abdominal cavity, there's a good chance that you're going to have a very sick, very sick patient. These patients normally exhibit signs of shock late, and this can end in death and serious death and serious condition. Here's just some examples of your solid organs and hollow organs that are contained in the abdominal cavity. Your spleen, liver, pancreas, and kidneys are solid organs. As we were mentioning earlier, the solid organs are actually rich with blood vessels, and they have a large blood supply that flows to them. So if they're injured, they do hemorrhage. The hollow organs, you have your stomach, your gallbladder, duodenum, large intestine, small intestine, and bladder. So if we have the contents spill out, we can end up with irritation of the lining of the abdominal cavity there. The functions of most of the organs contained in the abdomen involve the digestion of food, the absorption of nutrients into the body, and getting waste and excreting it from the body. Here's table 23.1 in your book, abdominal structures. It's just showing and driving home basically a list. You have your appendix, your bladder, common bile duct, fallopian tubes, gallbladder, intestines, stomach, uterus, and ureters as considered under hollow organs. Some of these are gender specific, such as the fallopian tubes and the uterus. Your solid organs here are kidneys, liver, ovaries, pancreas, and spleen. As we talked about earlier, these solid organs right here are rich with a blood supply. So if something happens to them, you have the capacity to bleed out into the abdominal cavity and cause peritonitis. And your major vascular structures, the abdominal aorta and the inferior vena cava, if you have an injury to those major blood vessels such as those, you end up with a patient that could potentially die from massive hemorrhage and blood loss into the abdominal cavity. Table 23-2, organs of the abdomen and their functions, basically just breaks down the functions of some of these organs that are contained in your abdomen. Stomach, I think everybody knows what a stomach is, but I'll leave these up here for a few seconds so you can cross-reference with your book. Go on to the next here. And talk about the acute abdomen. Abdominal pain. Abdominal organ emergencies don't typically create a perception of cutting or tearing. You can have all different types of pain resulting from these mechanisms, stretching, inflammation, ischemia. There's different causes of abdominal pain, and understanding how that pain is relating to your patient, how your patient is experiencing that pain, is important in the assessment and finding out of what we can do to treat this patient. As I mentioned earlier, abdominal organ emergencies don't typically create a perception of cutting or tearing. They're not usually associated with sensations like that, but the only exception is the aorta. You can have certain complications that cause a tearing sensation. It has been reported that a tearing complaint occurs in only a small number of patients experiencing a ruptured or dissected aorta. For the other abdominal viscera, if an organ is torn, the pain does not result from the tearing of the organ, but from blood irritating the peritoneum. So that blood irritating the peritoneal lining of the abdominal cavity can actually cause a different type of pain. Talk about the types of abdominal pain here. Visceral pain arises from organs and can be less severe, more generalized. It's really hard to localize exactly where the pain originates from. It can be dull or aching, usually some of the descriptors that patients use to describe it. It can be constant or it can be intermittent. So it can be something that lasts and doesn't let up at all, or it can come and go in waves. Although the pain might not be severe, you can still have something serious going on underneath the pathology behind it can actually be something underlying that we're not looking at and we're overlooking. So this is one of the most important lessons to learn from the different types of pain, because mild and intermittent pain doesn't mean that it could be something insignificant. It's still a significant finding. Parietal pain, second type of abdominal pain. It arises from the peritoneum. It's more severe, it's more localized, it's sharp, and it's constant. It's also called somatic pain, and it's, like I said, associated with the peritoneal lining becoming irritated. Remember, the peritoneum has a large number of highly sensitized nerve endings. So with that higher number of nerve endings, you get more sensation. You would expect the pain to be more severe and more localized. It's easier to pinpoint with one finger where exactly the pain is coming from. It's intense, and it's usually found on one side or the other, categorized as sharp, and it's typically going to be constant. It's not going to be intermittent. So if it's something persistent and described as sharp, we know that we have something that's irritating the parietal peritoneum. And we're going to talk also about referred pain. Referred pain is basically categorized as pain that's felt somewhere other than where the actual origin of the pain is located from. So it's usually pain from an organ. You have it's not actually felt in the organ itself, it's felt elsewhere in the body. So it's poorly localized, but it's felt consistently in the part of the body to which it refers to. So you have organs that share a nerve pathway with the skin sensory nerve, and that's where it comes from. So what happens here is, looking at this diagram here, you can look at different regions here, where the liver is actually contained in the abdomen, but if they have pain in their neck on either side here or here, that can actually be a sign that the patient is having something going on with the liver. And it's just that they have a nerve that is referring that pain from the liver to this point. The brain becomes confused in the interpretation of the impulse and causes the patient to feel pain at a location that's completely unrelated to where the organ is. So, speaking of the acute abdominal pain patient, there are several causes that can cause this type of presentation in a patient. Hospital care is usually required, especially in cases where pain has been persistent for 6 hours or greater. That's usually considered a surgical case, and exploratory surgery needs to be done to figure out what's going on. Do not spend time at the scene trying to figure out what the exact cause of the pain is. There are several instances that this patient would be in requirement for exploratory surgery to figure out what's going on, and definitive care would be the answer for the appropriate treatment for that patient. And here we can see several conditions that may cause an acute abdomen or an acute abdominal pain patient. Peritonitis, very broad term, it just explains the inflammation of the peritoneum. Appendicitis, so inflammation of our appendix. Pancreatitis, inflammation of the pancreas. Cholecystitis, inflammation of our gallbladder. Gastrointestinal bleeding, when you have bleeding into the GI tract, that can cause referred pain. It can also cause pain in the actual structures. Gastroenteritis, where we have inflammation there in the GI tract. Peptic ulcer disease, where ulcers have developed and we have irritation of the ulcer site. Intestinal obstruction, you may actually have either a foreign body that's lodged in the intestine, or the intestine has several different ways of becoming impinged and unable to follow through on its job. A hernia, and also abdominal aortic aneurysms. Sometimes you'll have abdominal contents that are acidic or alkaline that leak into the abdominal cavity. That can irritate the peritoneum and produce a sudden onset of severe, sharp, and constant abdominal pain. Let's take a look at peritonitis real quick. It's caused by peritoneal inflammation. You can have blood, pus, bacteria, or chemical substance leak into the peritoneal cavity. Onset and type of the abdominal pain that a patient experiences are somewhat dependent on what the substance leaking into the peritoneum is. You can have some of the signs and symptoms: abdominal pain or tenderness, nausea, vomiting, diarrhea, fever, chills, lack of appetite, and a positive Markle test. As an alternative to the rebound tenderness test, the Markle test has been shown to be just as reliable, but without the number of false positives or negatives seen with the rebound tenderness test. For the Markle technique, instruct the patient to stand on their feet with their knees straight, then ask them to raise themselves onto their shoes and drop suddenly down on their heels, flat-footed, with enough force to produce an audible thump. Basically, you ask your patient to stand on their tiptoes and then drop down to their heels. So if they drop down to their heels and they have referred pain into that spot of the abdomen, that is what we call a positive Markle test. Now, a unique presentation here: if the patient is unable to stand, too weak to stand, and they're laying in a bed or something like that, you could also reproduce the Markle test results by elevating the heel off of the bed slightly and tapping the heel of the foot on either side, and it will give you the alternative to a standing Markle test. Alright, appendicitis is the inflammation of the appendix that commonly causes an acute abdomen. Appendicitis is usually caused by a blockage in the intestines and results in inflammation and irritation. If it's not treated, the inflammation eventually causes the tissue to die and rupture. So definitive care is going to be surgery for this. You see it a lot in kids and young adults. So our treatment for this is going to be to get them to definitive care so they can perform surgical intervention. Some of the signs and symptoms to look for with appendicitis are going to be the periumbilical abdominal pain. So they're going to have some pain around where their belly button is. It's also going to be able to be localized to the right lower quadrant. They're going to have nausea and vomiting. They may have a low-grade fever with chills. Lack of appetite, which is going to be something common you see with abdominal complaints, is that the patient just doesn't have an appetite because it makes them sick to their stomach. They'll also have some abdominal guarding, to where they don't want to take the chance on anything touching that point in their abdomen, so they kind of guard it and shield it, and they also have a positive Markle sign, especially in the about to rupture or ruptured appendix. Talking about pancreatitis, pancreatitis is merely a term for inflammation of the pancreas. It can cause severe pain, especially in the middle of the upper quadrants, the epigastric area of the abdomen. Abdominal pain sometimes radiate to the mid to lower back. They're going to have pain, tenderness, distension, so the abdomen will be slightly distended out. The pain may radiate from the umbilicus straight through to the back. They may have a jaundice appearance, which is kind of like a yellowing of the skin, also a fever, and can potentially show signs of shock. Cholecystitis is classified as inflammation of the gallbladder. It's commonly associated with gallstones. Condition rarely occurs in children. In some cases of cholecystitis, the gallstones actually block the opening of the gallbladder to the small intestine, and this blockage causes an increase in pressure inside the gallbladder, which can cause severe pain. So when one of these hollow organs is distended, what kind of pain would you expect it to be? That's right, it'd be the visceral pain. Usually often occurs in patients between the ages of 30 and 50. It's more common in women, but without treatment, complications can occur. You're also going to see some upper middle to upper right quadrant abdominal pain. Tenderness, especially in the right upper quadrant. Patients usually going to belch, complain of heartburn, and have some nausea and vomiting. Definitive care for this condition is hospitalization and sometimes surgical intervention to remove the gallbladder or take out the stones or fix the blockage. If left untreated, you can end up with tissue death, perforation, or pancreatitis. In gastrointestinal bleeding, this is what you're going to see commonly referred to in the field as a GI bleed. It can occur at any point in the GI tract. So it's classified as upper or lower usually. It has a lot of causes, a lot of contributing factors that cause them, including ulcers, esophageal varices, diverticulosis. It most commonly affects people between the ages of 40s and 70s, so somewhere between the age of 40 to 80, but children and younger adults can experience it too. Some of your signs and symptoms associated with GI bleeds: be looking for abdominal pain or tenderness, hematemesis, hematochezia, melena, which just hematemesis is vomiting blood, Hematochezia is defecating blood, and also the melena would be blood mixed in with the stool. Altered mental status, weakness, syncope. Some of the signs that you would see with patients who are, um, having signs and symptoms of shock. A lot of these go hand in hand, especially when we're talking about GI bleeding. GI bleeding and shock can be closely related. So these patients that are acute abdominal patients, it would be a good idea to watch them for signs and symptoms of shock. Wouldn't you agree? In reference to the hematemesis, the vomiting blood, it can be bright red or can look like coffee grounds. Also, the hematochezia, you're gonna have bright red blood in the stool, and that's normally a signification of a rapid onset of the GI bleed. The melena is going to be dark tarry stools containing decomposing blood, and that's normally an indication of a upper GI bleed. Esophageal varices are basically categorized as engorged, weakened veins in the esophagus, the actual sheath of the vein. The vein actually comes out of the sheath and is exposed in the esophagus. It's commonly caused by heavy alcohol use or liver disease. It's caused by increased pressure in the venous blood supply system of the liver, stomach, and esophagus. It's known commonly as portal hypertension. It's usually painless, but bleeding can be profuse. I've seen these patients actually have to be sedated, paralyzed, and intubated due to not being able to control their airway. They can't stop the bleeding long enough. They can't get the blood out of their airway. So this is a very, very serious condition, and airway management can be very challenging. So these patients, sometimes you would consider calling ALS on to get a advanced airway in place if the seriousness of the case is warranted. Esophageal varices are characterized with large amounts of bright red hematemesis. So they're vomiting large amounts of bright red blood. No real pain or tenderness in the abdomen. Their pulse is rapid, tachycardic, have difficulty breathing. They have signs of shock, so they're pale, cool, clammy skin, and jaundice. Like I said earlier, jaundice is yellowing of the skin or sclera of the eyes and can indicate liver disease. And here we have a diagram showing the attachment of the vessels, the portal hypertension coming from the vein. You have high pressure hypertension on this vessel here, so when it off branches here, the pressure continues on and these vessels become engorged. And this is what a esophageal varix looks like, the singular tense of this. So we have looks to be a still frame from an EGD. Gastroenteritis is just inflammation of the stomach and small intestines. It's commonly associated with the presence of abdominal pelvic pain. It can be chronic or acute. It's often caused by some type of infection. Some of your signs and symptoms: abdominal pain, cramping, nausea, vomiting, diarrhea, abdominal tenderness, fever, dehydration, signs of shock in severe cases. If it's left untreated, it can result in the breakdown of the mucosal layers in the GI tract, and this breakdown can lead to the dehydration, hemorrhage, ulceration, and perforation of the GI tract. Ulcers, classified as open sores in the stomach or beginning of the small intestine, they may result in bleeding or perforation. They're usually associated with a breakdown in the lining that normally protects the intestine from the digestive fluids contained inside the digestive tract. The breakdown can cause damage to the stomach or intestine, and in some cases cause massive bleeding or perforation of a bowel. And here's just a illustrated example. The location of where the ulcer is can result in hematemesis, hematochezia, or melena, depending on the location and how bad it's bleeding. And here's an endoscopic view of an ulcer in the small intestine. Some of the signs and symptoms of an ulcer: Sudden onset left upper quadrant or epigastric pain, nausea, vomiting, hematemesis, hematochezia, or melena. Signs of shock in cases of severe bleeding, depending on how large the ulcer is or the abundance of ulcers. And if the GI tract that is affected by the ulcer is perforated, you may have peritonitis because, as we talked about earlier, the contents can spill into the peritoneal cavity and irritate that lining. Most patients who have ulcers, they're aware of them, and they will give you that information during the history obtainment process during your assessment. In some cases, the patient takes over-the-counter antacids or even prescribed medications for their condition. Intestinal obstructions, it's a blockage. It's a broad term that's used to describe a blockage that interrupts the normal flow of basically intestinal contents from one end to the other. This condition can occur in both small and large intestines, can be either partial or complete. It may result from having a tumor, fecal impaction, or adhesions from previous abdominal surgery. When you do your assessment and your patient has what looks to be scars on them, ask them if they've ever had exploratory abdominal surgery or any kind of abdominal surgery, period. If it's left untreated, we can lead to sepsis, perforation of the contents into the abdominal cavity, actually decreased blood flow and death of the intestinal tissue, and inflammation of the peritoneum. These patients will present with abdominal pain, nausea and vomiting, constipation, abdominal distension, tenderness, prominent high-pitched bowel sounds, diminished or absent bowel sounds. The patient with intestinal obstruction might want to continue to walk and move, whereas the patient with peritonitis might want to lie still and not be moved or touched. These patients are very, very conscious of what's going to make them hurt, because the swelling and distension of the abdomen will make it very, very uncomfortable for them. In severe cases of a complete blockage, you can actually have a patient that is vomiting fecal material. Hernias, protrusion of the intestine through an opening or weakness in the abdominal wall, so it gets pinched off and kinked. It's associated with increased pressure in the abdominal cavity. The bowel may become incarcerated, so a portion of it gets locked up. Most hernias are not life-threatening, can be easily treated. Sometimes it requires surgical intervention. Signs and symptoms for a hernia, looking at it from a standpoint, ask your patient that has abdominal pain, what were they doing when it started? You ask that question and they say they were lifting or straining, it's a good indication that it possibly is due to a hernia. They may have a fever, they may be tachycardic, or have a tender mass at the side of the hernia. Signs and symptoms of an intestinal obstruction. In some cases, the hernia become incarcerated or strangulated, and it causes that portion of the intestine to be pinched or cut off, and that's what causes your obstruction. Abdominal aortic aneurysms are commonly called in the field as a triple A. You have a weakened portion of the vessel wall, so the inner portion of the aorta swells out, or the outer portion swells out. There's a couple of different types, but anyway, the aorta balloons out and it can rupture. Men over the age of 60 is something that is the demographic that's most common in. Aneurysms can eventually rupture and is actually one of the most lethal causes of abdominal pain. You can lose blood so fast in these patients that if it occurred on the operating room table with you scrubbed into surgery, ready to repair it, there's a very, very slim possibility you're going to be able to save that patient. Here's just a illustrated depiction of what it looks like. You notice here you have the normal diameter of the aorta, and here the lining has started to swell out, and when it gets to a certain point it will burst. And here's a depiction of what happens actually is the lining of the vessel, there's a small tear in it, so we start to have leakage and a dissection here in the middle layer of the lining, and it begins to balloon out. When it balloons out, it's when we have our aortic tearing and dissection, an aneurysm. Signs and symptoms to look for with a AAA: gradual onset of lumbar, groin, and abdominal pain. If it ruptures, you're going to have a sudden onset of severe constant pain of the lower back, flank, or pelvis. It's usually categorized as tearing. In male patients, you'll have testicular pain. The process of dissection continues with increasing pressure until the outer wall is damaged and blood leaks out behind the peritoneum or into the abdominal cavity. These patients will often present with nausea, vomiting, have a very mottled or spotty abdominal skin. They'll be pale, cool, clammy, cyanotic, very shocky looking. They'll have absent, decreased femoral or pedal pulses because there's a blood flow interruption if you have a dissection or aneurysm. And skin below the waist may be cyanotic, cold, or mottled. If you suspect your patient has a AAA, don't palpate the abdomen. Pressure or excessive movement can aggravate the aneurysm, causing it to leak and rupture if it hasn't already. And just to reiterate, here, do not palpate the abdomen. Do not continue to palpate a pulsating mass. We don't want to increase the pressure on the vessel. Assess your patient for shock and transport the patient without delay. You may feel that pulsating mass. The abdomen may be rigid and tender if the rupture has occurred because our peritoneums are irritated. That assessment for shock is very, very crucial. These are high priority rapid transport patients, and if the rupture is in the process of occurring, it is a true emergency. Vomiting, diarrhea, constipation, associated with many acute abdominal disorders. These are the symptoms of a lot of different conditions that you can have. If you have these symptoms alone, unknown etiology, it can cause you to have abdominal pain. Also may lead to dehydration serious enough to cause shock. So you should be really concerned when the patient has diarrhea that has been persistent for days. In the case of vomiting, it can only take hours. If the patient's become dehydrated, that can open the door up for numerous other problems down the road. Let's take a quick look at some of the considerations in special POPs with abdominal pain, especially in pediatrics. Some of the questions that you would want to ask yourself or ask the parents, just using your observation and using what the parents have observed. Has the child been more irritable than normal recently? Can you console the child when they're crying or upset? And has the child had poor feeding habits recently? Young pediatric patients, especially infants, they can't really communicate what their symptoms are. Therefore, get as much of a good history as you can from the parent or primary caregiver. It's very important for your EMS workers to transport any child suspecting of having abdominal pain, even if the vital signs appear to be within normal limits for that child's age, due to the fact that kids compensate so well. You could have a severe condition going on there, and the compensatory mechanism for pediatrics could hide it very, very easily. Looking at the geriatric patient population, they have a decreased perception of abdominal pain, and they may wait longer to seek medical care for whatever the reason may be. Immunocompromised patients, they have a poor inflammatory response to abdominal conditions. When conducting a history on immunocompromised patients, it is important to ask about fever, vomiting, diarrhea, similar episodes in the past, and any recent changes in medications or treatment. Be sure to ask any transplant surgery patient about the date and location of the surgery. Bariatric surgery patients is one to take into consideration. They're at higher risk for ulcers, perforations, and obstruction of the bowel. Within 1 year of surgery, 20% of post-bariatric surgery patients are admitted to the hospital. Within 3 years, 40% are hospitalized. Abdominal complaints in post-bariatric surgery patients could be an indication of a very serious condition. I'm going to conclude that as part 1, and we'll pick up with part 2 in the next video.